Hello class, I'd like to go over the Starling forces again. Now before I go through these forces, I want to skip ahead 2 slides and just show you an equation. The filtration equation is shown up here as KF. Now let me explain what filtration is. Filtration is a way of calculating how much fluid will leave the lumen of the capillary bed and then go into the interstitial space. So we have blood volume, plasma volume, leaving the capillary and going into the interstitial fluid, turning into interstitial fluid. The purpose, of course, is to bring new nutrients to the cells and oxygen. So we want that outward movement of fluid. Now, how much fluid actually moves from the lumen to the interstitial space is predicated on the following forces. First, KF. How permeable is the capillary anyway? How large are the intercellular clefts? Are they gaping or are they pretty close together? Remember, those intercellular clefts are the spaces in between the endothelial cells of the capillary. I like to think of it like the endothelial cells are paver stones, and then the concrete or dirt that's in between them would be an intercellular cleft. Now, what are the other forces at play for filtration? The Starling forces. We have 2 hydrostatic pressures and 2 osmotic pressures. Now I'd like to back up and review those pressures. Let's first talk about hydrostatic pressure. A hydrostatic pressure is the force exerted by a fluid on a vessel wall or a container. Now, the fluid can be within the container or vessel, and there also can be fluid external to the vessel. Now let's look at our capillary hydrostatic pressure and interstitial fluid pressure. These are shown here as PC and PIF. We would predict that the capillary hydrostatic pressure would exert a force outward from the lumen outward, promoting fluid to leave the lumen of the vessel into the interstitial space. Now, capillary hydrostatic pressure changes from the arterial end, closest to the heart, to the venous side. So there's an average capillary hydrostatic pressure of 17.3 millimeters of mercury. Now, interstitial fluid pressure, we would predict, would oppose this movement of fluid from the capillary hydrostatic pressure. We would predict that interstitial fluid pressure would push internal into the lumen of the capillary bed. Now, we would predict this pressure to be a positive pressure, meaning pushing inward. But let's remember that there are lymphatic vessels. They are suctioning off this interstitial fluid. They are acting like a vacuum, a straw, if you will. And so this value is a negative value. This pressure is a negative pressure. It is minus 3 millimeters of mercury. Now I would write these values down. I would make a list of these 4 Starling forces. And I would add together the forces that favor outward movement and subtract from them the forces that favor internal movement. Now before we can do that, we need to discuss the colloid pressures. There are 2 colloid pressures. Now in the picture, plasma colloid osmotic pressure is designated as pi P. But on my actual typed slide, you'll notice that I changed it to pi C. I think it's just easier for me to remember pi as colloid osmotic pressure and C, I think, inside the capillary. So I'm using the letter C to be consistent with the capillary hydrostatic pressure, the letter C that was used for that force. So capillary colloid osmotic pressure. What is osmotic pressure? An osmotic pressure is generated by the number of particles, number of solutes, in a unit volume of solution. Now, if there are unequal number of particles per volume of solution across the cell membrane, then the side that has the highest particle count, particles suck, I'll remind you, will draw fluid to that side. Water will move to the side with the highest number of particles. Now I'll remind you, water moves for two reasons: hydrostatic pressure, the physical push on the vessel wall, and colloid osmotic pressure, or number of particles. In this case, colloid refers to the amount of particles from proteins. Colloid is a fancy name for a protein soup, proteinaceous soup. Now, the most abundant plasma protein is albumin, followed by the globulins. Now, there are also proteins in the interstitial space, but the number of proteins in the capillary are greater than the number of proteins in the interstitial space. So the plasma or capillary colloid osmotic pressure has a pressure of 28 millimeters of mercury, and this most certainly favors internal movement of fluid going into the capillary. The interstitial fluid from the proteins in the interstitial space, they are not as abundant, so it's not as strong. That force, that pressure, is 8 millimeters of mercury. Now, I'd be writing this down on this picture right now. Look critically at this picture. We see two arrows favoring movement out of the capillary into the interstitial space, and two forces that would favor inward movement of fluid from the interstitial space into the capillary. I would be writing down my forces, the values, on these arrows right now. For capillary hydrostatic pressure, right next to that arrow, I would write 17.3 millimeters of mercury. For interstitial fluid pressure, I would write next to that arrow, -3 millimeters of mercury. For plasma colloid osmotic pressure, capillary colloid osmotic pressure, I would put 28 millimeters of mercury. And for interstitial fluid colloid osmotic pressure, I would put 8 millimeters of mercury. Now, if we were to add together the values from those arrows, if we were to add the outward promoting forces, we would add together capillary hydrostatic pressure, 17.3, and the interstitial fluid colloid osmotic pressure, 8. We could then subtract from that all the forces that favor outward movement. We would subtract away plasma colloid osmotic pressure, which is 28, but careful, we would also subtract a -3 for interstitial fluid pressure. Now, what do you get when you subtract a negative number? A positive. Subtraction means you are adding a negative number. So you are adding a -1, let's say. If you multiply a -1 times a negative number, say -3, a negative times a negative gives a positive. So look very carefully. If you look at my column for total outward force, shown here in red, you will see that I've added together the 17.3 for the capillary hydrostatic pressure. We saw that in our picture. The 8 for the interstitial fluid osmotic pressure. But then I'm also adding the interstitial hydrostatic pressure, 3 millimeters of mercury, because subtracting a negative value makes it a positive value. And I'll remind you that lymphatic drainage is acting like a vacuum. It's promoting fluid leaving the interstitial space. So in actuality, that force with the arrow facing into the capillary lumen, it would actually be drawn facing away. We have 3 of our 4 Starling forces favoring outward movement. Fluid leaving the capillary to the interstitial space. And that leaves our only remaining force, the plasma or capillary colloid osmotic pressure 28 millimeters of mercury on its own. Now look really carefully at the red value versus the blue. There is a net outward drive of 0.3 millimeters of mercury. That means we have net filtration pressure of 0.3 millimeters of mercury. This is enough pressure to cause us to lose 2 milliliters per minute of our plasma volume throughout our entire body. That means if we did not have the ability to reclaim that lost, leaked fluid from the plasma, in one day we would lose 2 to 4 liters of our blood volume, and that would not be compatible with life. Now, what is reclaiming the interstitial fluid and returning it to the cardiovascular system? The lymphatic vessels. If we did not have them returning that lost, leaked fluid, we'd lose about more than half of our blood volume in a single day into our interstitial spaces. And our poor fluid intake would probably not keep up with that loss. So we need our lymphatic vessels. Now, here's another way of looking at this fight between our Starling forces. Let's look at our filtration equation again. The permeability coefficient, the KF, that should not be changing on a moment-to-moment basis. Now, will I teach you cases when it can change? Sure. But it should be relatively stable from moment to moment. Now let's look at our 4 Starling forces in the parentheses in the equation down here. Stop and think. I would write them in. Again, I don't need you to know numbers for the test, but perhaps the numbers written in here is warranted for you to get the big concept. Look, capillary hydrostatic pressure was what? 17.3. Hydrostatic pressure from the interstitial fluid was a negative value, -3. The hydrostatic pressure, the colloid osmotic pressure from the interstitial fluid was 8, and the capillary hydrostatic pressure was 28. Let's play with the 2 biggies. The 2 forces that have the strongest effects are going to be the capillary hydrostatic pressure and the capillary osmotic pressure, colloid osmotic pressure. Now look at this line, 2 lines. Look at this graph. This graph, look at the x-axis down here. I have on the left arterial end and on the right venous end. What this x-axis is representing is blood flowing through a capillary bed from the arterial end to the venous end. That's how blood flows, right? Now look in the red dashed line. The red dashed line shows capillary hydrostatic pressure. The red dashed line shows capillary colloid osmotic pressure. That's the amount of albumin and globulins. Those aren't changing from moment to moment. They're pretty stable. Their sheer quantities are stable. Now what does change across the capillary bed? The capillary hydrostatic pressure, of course. So as blood is flowing from the arterial end to the venous end, the capillary hydrostatic pressure, shown here in the green line, is higher than the capillary colloid osmotic pressure. Why do I say that? At the arterial end, the capillary hydrostatic pressure is 30. Capillary colloid osmotic pressure, I would write this value next to the red dashed line, is 28. I'll remind you that capillary hydrostatic pressure favors outward movement of fluid. So if capillary hydrostatic pressure is 30, that's higher than 28, which is capillary colloid osmotic pressure. Therefore, there will be a net loss of fluid. Fluid will leave the capillary lumen and go to the interstitial space. Now, what is going to happen as fluid leaves? Well, as fluid leaves, then the capillary hydrostatic pressure will also drop, right? There's less fluid exerted on the vessel wall. So that's why my green line tilts down and to the right. to represent that there's fluid loss. And by the time you get towards the venous end, the capillary hydrostatic pressure drops to 10 millimeters of mercury. Now at that point, towards the venous end, capillary hydrostatic pressure is now less than capillary colloid osmotic pressure, which is still 28. So as soon as the capillary hydrostatic pressure drops below capillary colloid osmotic pressure, as soon as our green line is below our red dashed line, now the Starling forces favor inward movement of fluid into the capillary bed. It's genius. Look at the picture, the top right up here. You're going to see in red the capillary bed closest to the artery, and then the capillary bed closest to the vein wall. Look at the arrows coming and going, favoring fluid leaving the capillary versus going back in. The forces, the Starling forces, are stronger at the arterial end to promote outward movement of fluid. And as the fluid leaves and renews and freshens up that interstitial fluid, the capillary hydrostatic pressure drops. And when it drops enough, the colloid capillary osmotic pressure is now higher than the hydrostatic pressure. And the arrows now are favoring inward movement of fluid. So we have the perfect system, don't we? We have forces favoring outward movement of fluid. Drop off the fluid, drop off the plasma, have it go to the interstitial space. As it moves into the interstitial space, it's now called interstitial fluid. It's plasma derived. It's similar to plasma, but it's not identical to it, so we have to call it a different name, interstitial fluid. But then, as the hydrostatic pressure drops in the capillary, and the capillary colloid osmotic pressure is now higher than the hydrostatic pressure, now this is going to act like a suction for the interstitial fluid to be brought back into the capillary bed. And this is perfect because now we're removing the waste and the CO2 from the interstitial fluid, and we're bringing that into the blood vessel so we can carry it to the kidneys and get rid of those wastes, right? So arterial end, drop off, renew, freshen up. Venous end, pick up the waste. And it's all because of these forces. At one side, hydrostatic pressure is higher at the arterial side, and then at the venous side, the capillary colloid osmotic pressure is highest. It's a perfect system. As long as it's not disrupted, of course, because if it's disrupted, well then we're going to get an imbalance between these forces, and this is when we're going to get the edema, of course, and I'm going to address that in the next few slides. So again, in the purple box here, if and when capillary blood pressure is less than capillary colloid osmotic pressure, then there will be a net movement of fluid into the capillary. Now, let's stop and think. Are these forces truly equal? Do we get equal drop-off of fluid? Do we get equal fluid leaving the capillary bed going into the interstitial space as we do interstitial fluid going back into the capillary? And the answer is no. The answer is, my friends, here on the previous slide, we see, if we take all these forces throughout the entire capillary bed, we still see that the capillary hydrostatic pressure outmatches the colloid osmotic pressure, such that there is a net outward filtration, meaning we have more fluid leaving than re-entering. And that is the reason why we need our lymphatic vessels to reclaim that net 2 milliliters per minute of lost leaked fluid. Yes, so we should review our anatomy of our lymphatic vessels. These are blind-ended vessels. That means they begin at the capillary bed, and shown in here in green in the picture are lymphatic vessels. So we start out with the smallest one, the lymphatic capillary, blind-ended. Now, the lymphatic fluid inside the lymphatic capillary is moving into larger lymphatic vessels, which will merge into larger trunks, which will merge into ducts, right? You remember the thoracic duct or the right lymphatic duct if a person has it. And these are returning the fluid where the jugular vein meets with the subclavian vein, and that's where your thoracic duct and right lymphatic duct would return this lost leaked fluid. So the fluid is going to move from the interstitial space into the lymphatic capillaries, and this fluid moves because of pressure changes. The pressure in the interstitial space is higher than the pressure in the lymphatic capillary. So the fluid moves through these little valves, these little overlaps of the endothelial cells of the lymphatic vessel, the lymphatic capillary. And these valves, these little leaflets, how they work, they won't allow fluid to leak backwards from the lymphatic capillary back into the interstitial space. So lymphatic fluid is similar to plasma. It's derived from plasma. It's got the fluid from plasma. It's got ions and sugars and proteins, but it's not the same as plasma. So it's got less protein than plasma. So we say it's lymphatic fluid, giving it a new name. It can also contain hormones, of course, bacteria, viruses, cellular debris, traveling immune cells like macrophages, and cancerous cells too that have metastasized. There is no pump to drive lymphatic fluid through the capillaries, to the vessels, to the trunks, to the ducts. There's no official pump like the heart pumps blood. There's no lymphatic pump. There is, however, we do use our skeletal muscle to help propel the lymphatic fluid, and I'll describe that in a moment. And our breathing also helps promote lymphatic fluid moving through the different lymphatic vessels. But there is no official driving force. There are valves inside the lymphatic vessels, and these are going to promote one-way movement of the lymphatic fluid, just like there were valves in the veins. Now, let's talk about causes of edema. If we have an accumulation of fluid in the interstitial space, that's edema. Now, for those of you who do not have Guyton and Hall, the textbook of medical physiology, I'm going to read from that page. And these two different page numbers here are if you have the old edition or the new edition. If you have the new 12th edition, I'm reading from page 297. Summary of causes of extracellular edema. A large number of conditions can cause fluid accumulation in the interstitial spaces by abnormal leaking of fluid from the capillaries or by preventing the lymphatics from returning fluid from the interstitium back to the circulation. So let me say that again. How can we get an excess of fluid accumulating in our interstitial spaces? A, either too much fluid coming from the capillary to the interstitial space, or B, the lymphatic vessels are no longer draining that fluid. Okay, that's clear. The following is a partial list of conditions that can cause extracellular edema. Okay, I would be writing down right now on this slide, if you're watching on a piece of paper, your Starling forces, your filtration equation. Filtration, the amount of fluid leaving a capillary, is dependent on how permeable the capillary bed is, Kf, times the Starling forces, with the forces favoring outward movement added together and the force favoring inward movement into the capillary bed subtracted from them. So I'll remind you that we have three Starling forces that traditionally favor outward movement: the capillary hydrostatic pressure, the colloid interstitial fluid pressure and the interstitial hydrostatic pressure, which is normally negative, -3. The only force under normal, healthy conditions that favors inward movement is the capillary colloid osmotic pressure, which we learned was 28 millimeters of mercury. So how can we get more filtration? 1, we can increase capillary hydrostatic pressure. How can capillary hydrostatic pressure go up? Well, reading from page 297, letter A, kidney retention of salt and water. Okay, if the kidneys are not working right, they are retaining more salt and water than they should. Maybe there's more mineral corticoid excess like aldosterone. Remember, aldosterone promotes more salt and water retention. Well, then our blood volume is going to go up, right? And if our blood volume goes up, then that means more blood pressure exerted on the capillary wall. So that 17.3 millimeters of mercury is going to go up to even a higher value, which means more fluid leaving into the interstitial space, and that means puffiness, the edema. What if the veins are not draining the blood? What if blood isn't able to go through the capillary bed and into the veins and back to the heart? What if there's right-sided heart failure? What if the right side of the heart is not being a good pump? Well, then that means the fluid is going to accumulate in the systemic circuit, right? What comes in is not going out on the right side of the heart. Central venous pressure is going up. Or maybe there's an obstruction in a vein. Maybe there's a thrombus, a deep vein thrombosis. If you cannot allow the blood to drain from the capillary bed through a venular vein, then there's going to be damming up of blood, and then that means there's going to be more blood pushing on the capillary wall. That means more capillary hydrostatic pressure, more edema. So you can have a venous obstruction, you can have a failure of the venous pumps. Let's say a person is standing for a long time and not using their skeletal muscle pump, then that means the blood is going to pool in the capillaries and more hydrostatic pressure, and the person presents with edema in their feet, right, at the end of a long day standing. Or if someone's paralyzed, they can get their muscles are not contracting anymore. Same thing. Immobilization of parts of the body, same thing. We're losing our skeletal muscle pump. All right, I'm not going to entertain too much letter C where it says decreased arterial resistance. If I'll just briefly talk about excessive body heat. If your body temperature goes up too much, you can have the arterial resistance decreases. The blood will just pool in the capillary bed. This is part of heat shock, right? We get stasis. We don't get effective blood pressure because the arteries, the tunica media, just relax. And that means the blood is pooling in the capillary bed, and it can go into the interstitial space. So I'm just going to focus on excessive body heat because we learned about that when we learned about thermoregulation and heat shock. What about number 2? Decreased plasma proteins. Well, if we have decreased plasma proteins, which Starling force are we going to affect? That's right, the capillary colloid osmotic pressure. We learned about this with kwashiorkor, the disease of the displaced child. The lack of the essential amino acids means that the liver is not making adequate amounts of albumin. Decreased albumin means decreased capillary colloid osmotic pressure, which means a lower value, no more 28 millimeters of mercury, it's lower. And now we have fewer particles in the plasma to help pull the fluid back into the capillary bed. And that means the fluid will accumulate in the interstitial space. So, we learned about kwashiorkor. That's caloric malnutrition, right? Or what if there's liver disease, cirrhosis of the liver? We learned about this too, that the alcoholic can have the ascites in the abdominal cavity, just like the ascites seen in the kwashiorkor child. But what else? What about loss of protein from the plasma compartment? Now, okay, be very careful with this one. There isn't a problem with creating or synthesizing albumin. It's there in its normal sufficient quantities in this example I'm about to give you, but it's allowed to leak through the capillary intercellular clefts more abundantly than it should be. Now, when can this happen? Loss of protein from denuded skin areas, say from burns. Now you've got plasma albumin and globulins going through that damaged tissue, the burn, maybe it's first degree, second degree. I mean, that's what kills them, right? When the burns are in great enough quantities over their body, they die from dehydration, right? And it's because they don't have an intact vessel wall. It's been burned through. And now the plasma proteins are going through to the surface of the body, if there's no skin anymore, and it's pulling the fluid with it. So you have the osmotic pressure from the albumin proteins working now to promote fluid to leave the capillary bed because those proteins are leaving the capillary bed. So in this case, we have now a problem with permeability, the KF. The burn has certainly increased that value. And we also have plasma proteins being lost. Now be very careful with this one. Let me be very clear. We do not have a decrease in plasma proteins. When we say a decrease in plasma proteins, we are referring to the liver not making them in sufficient quantity. A decrease in plasma proteins would mean a decrease in plasma colloid osmotic pressure, kwashiorkor, liver disease. But in the case of burns, the plasma colloid osmotic pressure is fine. That's still 28. But the plasma proteins are leaving the capillary bed, and they're going into the interstitial space. So I want you to think of it now as the interstitial colloid osmotic pressure going up aberrantly. That's the problem. So again, with burns, the problem with our equation, our filtration equation, will be KF. That value goes up in the case of burns. And the interstitial colloid osmotic pressure is going up, favoring more outward movement of fluid. Now, number 3, increased capillary permeability. Now we're talking KF. Okay, we've already talked about burns. Burns is going to change KF. We addressed that. But also histamine. Histamine is also going to lead to increased capillary permeability. Increased capillary permeability with histamine is changed. We're going to see histamine again in the next slide, and how histamine can affect more than one of these Starling forces. So we'll start out with increased capillary hydrostatic permeability. Now, something else, prolonged ischemia. This is really important, especially for students in pathophys to understand. When you have a tissue with prolonged ischemia, reduced blood flow, what's going to happen is that the tissues are accumulating waste products, right? They're accumulating adenosine. They're accumulating hydrogen and potassium. And what's going to happen is these are going to act as vasodilator agents. Yes, true. But if that blood vessel is still occluded and you don't get any blood fluid going through it, then the vasodilation is all for naught. And these same accumulation waste products can now change KF. That's really important that you know that. Because when the permeability goes up like this, we can actually see proteins that are going to be leaked from the tissue bed into the capillary. And we can actually detect these leaked, lost proteins from the tissue in the person's bloodstream. This happens when a person has coronary artery disease, a blocked coronary artery. The myocardium accumulates these waste products, leads to more KF, and we see that we can actually have proteins being lost by the cardiocytes from the cells into the bloodstream. And we can actually use these as markers to see if a patient has these lost, leaked heart proteins into the bloodstream. Lastly, letter 4, blockage of lymph return, and that's what I'm showing in these pictures. A person can have a filarial infection, nematodes, little roundworms. The W. bancrofti is the example of that nematode. This leads to elephantiasis, not elephantitis. An elephantitis, that's an inflamed elephant. And I have not heard of someone dying from an inflamed elephant. But elephantiasis, and the reason why they call it elephantiasis is because the edema accumulates in the lower extremities, shown here in the child's leg. And then they look like they have an elephant's leg, right? It's all swollen. The man has a very large scrotum in this picture from the elephantiasis. The fluid is going to accumulate in the areas with the least resistance. Soldiers used to go off to third world countries and they'd be afraid that they'd come back with their scrotum in a wheelbarrow. That's how they used to describe it. So if you block the lymphatic return from a filarial infection, then the fluid can accumulate in the interstitial space. What else can I say here? So I told you about the heart failure leading to edema. We also are going to see edema from valve problems of the heart. What if one of the valves is leaky or prolapse and allows regurgitation, backflow of blood? Well, then we're going to get blood not moving away from capillaries to venules to veins to the heart. We're going to get some of the blood from the heart backflowing into the veins and venules, and that means damming up of blood all the way back to the capillary bed, and that means increased capillary hydrostatic pressure. Okay, let's move on to the next slide. So here is a picture to demonstrate what I mean by unbalanced ventricular output, heart failure. Now, depending on which side of the heart is failing, is it the right ventricle or is it the left ventricle? That will dictate where we're going to see the edema. Let me explain. Okay, so let's talk about unbalanced ventricular output. In my previous example, I talked about the right side of the heart failing. Well, in this example, let's talk about the left side of the heart failing. How can this happen? Well, maybe the left ventricle is becoming overly hypertrophied, but as you can see in this picture, the hypertrophy is going into the left ventricular chamber, and that means that there isn't as much blood being ejected from the left side as it is from the right side. And so what happens is when the heart contracts, there's blood being pushed into the pulmonary circuit from the right ventricle, but there isn't as much blood being ejected out of the left ventricle into the systemic circuit. So the basic rule of thumb is whatever side is failing, then behind it, meaning the circuitry leading to that side of the heart, is going to present with the edema. So if we have more blood going to the pulmonary circuit than what's being pumped out by the left ventricle to the systemic circuit, then we're going to have the damming up of blood in the pulmonary circuit. There will be increased capillary hydrostatic pressure in the pulmonary capillary beds, as shown here in number 2, and that means an increase in the Starling force favoring outward fluid movement into the interstitial spaces of the lung. And that means the person can present with fluid inside their lungs, literally in the alveoli, because the fluid will go from the interstitial space into those air sacs. That's a problem. That's a big problem. Pulmonary edema is nothing to mess with, because now it's going to lead to a cascade of problems if we go back and we think about Fick's law for the rate of diffusion, one of the things that influences how quickly something will diffuse, of course, is the distance in which it needs to diffuse. So if you're talking about fluid accumulating in the alveolar sacs, now oxygen has to diffuse through that fluid in addition to the traditional respiratory membranes, the simple squamous epithelium of the alveolar sac, the fused basal laminas, and the simple squamous endothelium of the pulmonary capillary bed. So obviously, as blood is going through the pulmonary capillary beds, or not in this case, we're not going to get adequate loading of oxygen, and the person is most certainly going to be cyanotic. What about the right side? I've already used this example, but now there's a right-sided heart failure. We have the left side ejecting more blood than what's returning to the right side of the heart. Less in means less out. That means the capillary hydrostatic pressure is going to build, and that means we're going to get the edema in the systemic tissues. Now, these are examples from that page in Guyton and Hall 297 or whatever it was that I just went over with you. And these are ones that I would definitely know for our testing purposes. Let's start with hypertension. A person has essential hypertension. That essential means primary. 90% of all hypertensive patients, we don't know what causes it. So 90% of all cases of hypertension are primary or unknown reasons. Okay, if you have increased pressure on the blood inside the vessel, that means capillary hydrostatic pressure is going to go up. And that fluid has to go somewhere, so it's going to leak out of the capillary bed and into the interstitial space. So when we see, for example, women with preeclampsia, and we see that their blood pressure is going up, they oftentimes look puffy too. You can see the edema in their face, the bulging neck veins, etc. So interstitial fluid formation is a direct cause from that increased capillary hydrostatic pressure. Starvation, or caloric malnutrition, or kwashiorkor, shown here in green. That's a lack of dietary protein. That means the liver is not getting enough essential amino acids to make albumin. We know this leads to a decrease in albumin, the most abundant plasma protein. And that means your capillary colloid osmotic pressure will drop. That's the Starling force that's going to be disrupted the most. Okay, let me slow down. Excuse me, I'm fighting allergies. What is the purpose of this slide? The purpose of this slide is to help my current physiology students with a part in their homework packet. There's a part in your Lecture Unit 3 homework packet that asks you to identify which of the Starling forces is most directly affected that will lead to this edema. In the case of hypertension, the Starling force that's affected is the capillary hydrostatic pressure. In the case of starvation, why do we see the edema? It's a disruption in the capillary colloid osmotic pressure. Let me be very clear. You can reconcile, you can identify a patient's cause of edema if you know your Starling forces. And most of the time, not all, most of the time, it's going to be a problem with either capillary hydrostatic pressure or capillary colloid osmotic pressure. Most of the time. Not always. In the case of histamine, as a perfect example, histamine has two effects. It affects the capillary permeability. It will increase KF. But it also is a vasodilator. We learned that this week. And if it acts as an arterial vasodilator, that means more blood can flow to the capillary bed. And that means an increase in capillary hydrostatic pressure. that means more interstitial fluid formation for both reasons. So, on your exam, physiology students, if I ask you what will happen with an histamine excess, you should mark 2 answers on your test. Changes in KF, KF goes up, but also an increase in capillary hydrostatic pressure. Here are some more examples. What about a burn or a crushing injury? Now, I talked about this already. With a burn or crushing injury, we're going to have 2 things. Again, 2 issues. You should mark both on your test. Number 1, an increase in capillary permeability. Burns cause KF to go up. Number 2, we're going to see that there's going to be a drop in that capillary colloid osmotic pressure. That means the plasma proteins are leaving. Now, I want us to be able to discern between kwashiorkor and a burn crush. So, for testing purposes, hear me on this, and you might want to change something on this slide. With a person with a burn or crush injury, there isn't a problem with the liver. There isn't. So the total number of capillary or plasma proteins is fine. The issue is not with the liver. The issue is at the capillary bed where they are more leaky. So I guess I'm going to go for testing purposes, I'm going to renege on what I said earlier. I'm sorry about that, but I want to be very clear. Again, kwashiorkor, the alcoholic, the liver failure or malnutrition, etc., from the get-go, there are fewer plasma proteins. But with a person with a burn or crushing injury, the sheer number of plasma proteins was fine. But with the increased capillary permeability, now you have more of those plasma proteins leaking through the intercellular clefts and into the interstitial space. So how do we want to do this? We really can take either approach. In my earlier segment, I said the interstitial colloid osmotic pressure would go up, which is true, because the plasma proteins are leaking and going into the interstitial space. But that's not saying that the interstitial proteins in sheer quantity were synthesized more abundantly. That's not really the issue, right? What we have is a decrease in capillary colloid osmotic pressure from proteins leaking to the interstitial space. So I guess for testing purposes, I would want you to mark the following. For a burn or crush injury, an increase in capillary permeability, increase in KF, that's one of your answers. And number 2, a decrease in capillary colloid osmotic pressure, because those plasma proteins are being lost to the interstitial space. So those are the 2 that you would mark. Just please promise me that you'll recognize that it's not a problem with a person's liver not making albumin in the first place. Alright, in the last one here, I'm showing left ventricular failure. We recognize that if it's a left side problem, then we're going to see damming up of the blood in the vessels leading to the left side. That means we're going to see damming up of blood in the pulmonary circuit. So we're going to see increase in capillary hydrostatic pressure in the pulmonary capillary bed, leading to pulmonary edema. However, ahead of the left ventricle, meaning the blood vessels leaving from the left ventricle, like the aorta, the systemic circuit is going to have a reduced capillary hydrostatic pressure. That means they're going to have less blood pressure, and that's going to be a problem with systemic blood flow. Okay, that concludes our lecture, and on to cardiac problems. That is a huge lecture filled with nothing but pathophysiology, which is the reason why I'm including my pathophysiology in this lecture, the lecture of hemodynamics, as well as our next lecture. Because really, even with this hemodynamics lecture, I just covered a lot of pathophys. Excuse me, hope you enjoyed it.